Hello, guys. We continue our course of psychiatry, and today we'll talk about schizophrenia. Schizophrenia, it's a chronic, severe mental disorder that affects the way a person think, act, express emotions, perceive reality, and relate it to others. Though schizophrenia isn't as common as other minor mental illness, it can be the most chronic and disabling. People with schizophrenia often have problems doing well in society, at work, at school, and in relationship. They might feel frightened and withdrawal, and could appear to have lost touch with reality. This lifelong disease cannot be cured, but can be controlled with proper medication. Contrary to popular belief, schizophrenia isn't a split or multiple personality. Schizophrenia involves a psychosis, a type of mental illness in which a person can tell what's real from that's imagined. At times, people with psychotic disorder lose touch with reality. The world may seem like a jumble of confusion, thought, images, and sounds. Their behavior may be very strange and even shocking. A sudden change in personality and behavior, which happen when people who have it lose touch with reality, is called a psychotic episode. How severe schizophrenia is varied from person to person. Some people have only one psychotic episode, while others have many episodes during lifetime, but led a relatively normal life in between. Still others may have more trouble functioning over time, with little improvement between full-blown psychotic episodes. Schizophrenia symptoms seem to worsen and improve in circle known as relapse and remission. So when we talk about history of this disease, the primary evidence about it we can meet in a book of Hertz, part of the ancient Egyptian Ebers papyrus. However, study of the ancient Greek and Roman literature show that also the general population probably had an awareness of psychotic disorder. There was no recorded condition that would meet the modern criteria of schizophrenia. Symptoms resembling schizophrenia were reported in Arabic medical and psychological literature during the Middle Ages. It's the canon of medicine. For example, Avicenna described a condition somewhat resembling schizophrenia, which he called Janun Mufrit, or semia madness, which he distinguished from other forms of madness, such as mania, ravers, and manic depressive psychosis. The concept of madness was existed for thousands of years. Schizophrenia has only classified as a distinguished mental disorder by Emil Kraepelin in 1893. He was the first to make a distinction in the psychotic disorder between what he called dementia praecox, or early dementia, a term first used by psychiatrist Benedict Morel, and manic depression. Kraepelin believed that dementia praecox was primarily a disease of the brain, and the particular form of dementia distinguished from other form of dementia, such as Alzheimer's disease or any other type of neurodegenerative disease. Bloiler describes the main symptoms of 4A's: flattening affect, autism, impaired association of ideas, and ambivalence. Bloiler realized that the illness was not a dementia, as some of his patients improve rather than deteriorate, and hence proposed the term of schizophrenia instead of dementia praecox. The Schneiderian classification relate to the psychiatrist Kurt Schneider, listed the form of psychotic symptoms that the thought distinguished schizophrenia from other psychotic disorders. There are called first-rank symptoms or Schneider's first-rank symptoms that include delusions of being controlled by the external forces. They believe that thoughts are being inserted into or withdrawn from one's conscious mind. And they believe that one's thoughts are being broadcast to other people. And hearing hallucinatory voices that comment of one's thought or action. And the patient can have the conversation between these hallucinatory voices. What are the early symptoms of schizophrenia, and what's the general epidemiology of schizophrenia? The condition usually shows its first sign in men in their late teens for early 20s. It most affects women in their early 20s and 30s. The period when symptoms first start and before full psychosis is called the prodromal period. It can last days, in some cases weeks, or even years. It can be hard to spot because there's usually non-specific triggers. You might only notice subtle behavioral changes, especially in teens. And these behavioral changes can include a change in grades or social withdrawal, trouble concentrating, temper flares, and difficulty sleeping. So you can see that they are not specific symptoms, and we cannot recognize, according to the symptoms, that this person will have schizophrenia in the future. The modern classification of schizophrenic presentation divide all symptoms into several groups, and we talk about positive and negative symptoms. So what does it mean? In the case, the word positive doesn't mean good, but it's mean productive symptoms. But when something unusual appeared, something additional appeared in the general mental functioning or in the personality of the person. It refers to act, thought, or actions that aren't based in reality. They are sometimes called psychotic symptoms, and these positive symptoms include different types of delusion. When we talk about schizophrenia, the most particular type of delusion is delusion of persecution. Hallucination, in the case of schizophrenia, it's auditory hallucination or verbal hallucination, when patient can hear speech of other people, and in mostly cases, it's several voices inside patient mind. Catatonia, it's a condition the person may stop speaking, and their body may be fixed in a single position for a very long time. And beside to the group of positive symptoms below disorganized symptoms of schizophrenia. These are positive symptoms that show that the person cannot clearly or responds as expected. And examples of disorganized symptoms may be talking in sentence that doesn't make sense, or using nonsense words, making it difficult for the person to communicate or hold a conversation. Shifting quickly from one thought to the next without obvious or logical connection between them. Moving slowly or being unable to make decisions. Written excessively but without meaning. Forgetting or losing things. Repeating movement or gests like pacing or walking in circle, like a stereotypical behavior. Having problem making sense of everyday sights, sounds, and feelings. The cognitive symptoms of schizophrenia is a distinguished part of clinical presentation of schizophrenia, and the severity of cognitive symptoms depend on the duration of illness, how long the patient suffers from schizophrenia. The patient with cognitive symptoms will have trouble with understanding information and using it to make decision. A doctor might call this poor executive function, or focusing or attention or paying attention, using their information immediately after learning it. It's called a disorder of working memory. Recognizing that they have any of these problems also belong to the cognitive deficit. You can see data from PET study suggests that the less the frontal lobes are activated, red color, during a working memory task, the greater the increase in abnormal dopamine activity in the striatum, green, thought to be related to the neurocognitive deficit in schizophrenia. Negative symptoms, the word negative here does not mean bad. It notes the absence of normal behavior in people with schizophrenia, normal behavior or normal skills or abilities. Negative symptoms of schizophrenia include lack of emotions or limited range of emotions, withdrawal from family, friends, and social activity, less energy than previously, speaking less, lack of motivation, loss of pleasure or interest in life. We name this anhedonia. Poor hygiene and grooming habits. What cases of schizophrenia? The exact cases of schizophrenia isn't known, but like cancer or diabetes, schizophrenia is a real illness with a biological basis. Researchers have uncovered a number of things that appear to make someone more likely to get schizophrenia, and these signs include genetic factors or heredity. Schizophrenia can run in families, which means a greater likelihood to have schizophrenia may be passed from one parent to their children. Brain chemistry and the cures. People with schizophrenia may not be able to regulate brain chemicals called neurotransmitters that control certain pathway or circuits of nervous cells that affect thinking and behavior. Brain abnormalities. Researchers has found abnormal brain structure in people with schizophrenia. But this doesn't apply to all people with schizophrenia. It can affect people without this disease. Environmental. Things like viral infection, exposure to toxins like marijuana, or highly stressful situation may trigger schizophrenia in people whose genes make them more likely to get the disorder. And in modern medicine, we name this epigenetic, when some factors of surrounding can code or record some genes and show some traits or features. Schizophrenia more often surfaces when the body is having hormone or physical changes, like those that happen during the teens and young adult years. The relationship between schizophrenia and drug use is complex, meaning that a clear causal connection between drug use and schizophrenia. There is strong evidence that using certain drugs can trigger either the onset or relapse of schizophrenia in some people. It may also be the case, however, that people with schizophrenia use drugs to overcome negative feeling associated with both the commonly prescribed antipsychotics medication and condition itself, where the negative emotions, paranoia or anhedonia, are all considered to be core features. Who gets schizophrenia? Anyone can get schizophrenia. It affects people all over the world from all races and cultures, while it can happen in any age. Schizophrenia typically firstly appeared in the teenager years or early 20s. The disorder affected men and women equally. Thought symptoms generally appeared earlier in men. The earlier the symptoms start, the more severe the illness tend to be. Children over the age of 5 can have schizophrenia, but it's rare before adolescence. In Ukrainian literature, early schizophrenia we name gebephrenic schizophrenia. It's has a very dangerous impact to the development of personality, and the signs of schizophrenia, which start in early ages, look like behavioral disorder and disorder of personality connected with cognitive disorders. How is schizophrenia diagnosed? If symptoms of schizophrenia are present, the doctor will perform a complete medical history and sometimes a physical exam. While there are no laboratory tests to specifically diagnose of schizophrenia, the doctor may use various tests and possible blood test or brain image study to rule out other physical illness or intoxication. substance-induced psychosis, especially related to psychostimulants like amphetamine, cocaine, or psychodysliptics like LSD. If the doctor finds no other physical reason for schizophrenia symptoms, they may refer the patient to psychiatrist or psychologist, mental health professions trained to diagnose and treat mental illness. Psychiatrists and psychologists use specifically designed interview. We name this semi-structural interview, mini or SCID, and assess tools to evaluate a person for psychotic diseases. The therapists base their diagnosis on the person's and family's reports of symptoms and their observation of the person's attitude and behavior. A person is diagnosed with schizophrenia if they have at least two of these symptoms for at least 6 months. So the patient should have delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, negative symptoms. One of the symptoms has to be delusion, hallucination, or disorganized speech. During the 6 months, the person must have a month of active symptoms. It can be less with successful treatment. Symptoms should negatively affect their sociality or at work and cannot be caused by any other condition. If the patient doesn't fulfill these criteria and have only particular from them, for example, presence of symptoms like delusions, hallucination, but the duration less than months during last 3 months, we diagnose acute psychotic disorder with schizophrenia features, but not schizophrenia, because for diagnostic of schizophrenia, we should have the period for recognition of negative symptoms when we observe that the patient ability for socialization, to interaction with other and communication decrease. The patient law of energy also decrease in comparison with the previous one. What are the subtypes of schizophrenia? In classification, there are several subtypes or several forms of schizophrenia. We recognize simple form, catatonic form, gabaphrenic form, also known like disorganized form and paranoid form. The DSM contains 5 subclassifications of schizophrenia. Paranoid type, where delusions and hallucination are present, but thought disorder, disorganized behavior, and affective flattering are absent. Disorganized type, named hebephrenic schizophrenia in the ECD, where thought disorder and flat of affect are present together. Catatonic type, prominent psychomotor disturbances are evident. Symptoms can include catatonic stupor and waxy flexibility. Undifferentiated type, when psychotic symptoms are present but the criteria for paranoid, disorganized, or catatonic type have not been met. And residual type, where positive symptoms are present and a low intensity only. Besides, we recognize 2 other subtypes, particular for schizophrenia. It's post-schizophrenic depression, when a depressive episode arising in the aftermath of a schizophrenia relapse, where some low-level schizophrenic symptoms may still be present. And simple schizophrenia. It's insidious but progressive development of prominent negative symptoms with no history of psychotic episodes. So the patient with simple form of schizophrenia have no any hallucinations or delusions, but flattening of emotions, poor emotional response to external events, or anhedonia are present all over the time. So what are the signs and symptoms of each of these subtypes? For paranoid schizophrenia, particular different types of delusion, and we name this delusion of persecution or delusion of reference. Delusion of persecution is a strong belief that others, often a vague they, are out to get him or her. This persecutory delusion often involves bizarre ideas and plots. Martians are trying to poison me with radioactive particle delivered through my tap water. It's an example of patient speech. The other type of delusion in paranoid schizophrenia is delusion of reference. A natural environmental event is believed to have a special and personal meaning. For example, a person with schizophrenia might believe a billboard or a person on TV is sending a message meant especially for them. The next topic of delusion is delusion of grandeur. Believe that one is a famous or important figure, such as Jesus Christ or Napoleon. Alternatively, delusions of grandeur may involve the belief that one has unusual power that no one else has. For example, ability to fly, or is a son of the god, or the god talk to him and give some instructions because he is chosen. And the other type of delusion is delusion of control, believes that one thought or action are being controlled by outside alien force. Common delusions of control include thought broadcasting, my private thoughts are being transmitted to others, thought insertion, someone is planting thoughts in my head, and thought withdrawal. Somebody is robbing me and of my thoughts. Hallucination is also part of the clinical presentation of paranoid schizophrenia, and we talk about hallucinatory delusional syndrome. Hallucinations are sound or other sensation experienced as real when they exist only in the person's mind without any external stimulus. While hallucination can involve any of the five senses, auditory hallucination, hearing voices or some other sounds, are most common in schizophrenia. Visual hallucinations are also relatively common, and research suggests that auditory hallucinations occur when people misinterpret their own inner self-talk as coming from the outside thought. And in this case, we distinguish real hallucination and pseudo-hallucination. Pseudo-hallucination means that some features of real hallucination not fulfilled. The location of hallucinatory voices is inside the patient's body in the case of pseudo-hallucination. The patient reports this as, I can hear my with my inner ear, or I can hear my own mind, my own thoughts, and other people can know about this. Schizophrenic hallucinations are usually meaningful to the person experiencing them. Many times the voices are those of someone they know. Most commonly, the voices are critical, vulgar, and abusive. Hallucinations also tend to be worse when the person is alone. In some cases, in paranoid patients, we can meet some intrusive hallucination which give instructions or give orders. And if the patient is an acute period of disease, it's really danger situation because patient can follow to these instructions and can jump through the window, hurt himself or others. So during the interview, we should point attention to the presence of this type of hallucination and organize the over-day observation due to the patient and prescribe appropriate treatment, which can fastly take under control these sensations. The next specific symptom of paranoid schizophrenia is disorganized speech. Fragmented thinking is characteristic of schizophrenia. Externally, it can be observed in the way a person speaks. People with schizophrenia tend to have trouble concentrating and maintaining a train of thought. They may respond to queries with and are related answers, start sentences with one topic and end somewhere completely different, speak incoherently or say illogical things. Common signs of disorganized speech in schizophrenia include loss of association, when the patient rapidly shifts from one topic to other with no connection between one thought and the next. Neologism, made up words, new words, and phrases that only have meaning for the patient. Perseveration is the repetition of words and statements, saying the same things over and over. Clank, meaningless use of rhythmic words. I said to bread and read the stat and fat net at the head. It's an example of this illogical speech. Disorganized schizophrenia characterized by the next signs. It generally appeared at the earlier age than other subtypes of schizophrenia, and its onset is gradual rather than abrupt, with the person gradually retreating into his or her fantasies. The distinguishing characteristics of this subtype are disorganized speech, disorganized behavior, and flattered or inappropriate emotions. People with disorganized schizophrenia also have trouble taking care of themselves and may be unable to perform simple tasks such as bathing or feeding themselves. The symptoms of disorganized schizophrenia include impaired communicational skills, incomprehensive or illogical speech, and emotional indifference. Very often, doctors observe inappropriate reaction to the external stimulus, inappropriate emotional reaction. For example, in the sad situation, the patient can loudly laugh. Infantile behavior like baby talk, giggling, peculiar facial expression, and mannerism. People with disorganized schizophrenia sometimes suffer from hallucination and delusions, but unlike the paranoid subtype, their fantasies aren't consistent or organized. The next subtype is catatonic schizophrenia. The hallmark of catatonic schizophrenia is disturbances in movement, either a decrease in motor activity, reflection and stuporose stage, or an increase in motor activity, reflection, and excited stage. So we distinguish catatonic excitement or catatonic stupor, which depend on the prominent motor and other general syndromes. Stuporous motor signs reflected a dramatic reduction in activity. The person often is absent to perform any voluntary movement, cannot reply, there are no any speech, any conversation, and may be extremely resistant to any changes in his or her position, even to the point of holding an upwalked, uncomfortable position for hours. Excited motor signs or catatonic excitement characterized that sometimes people with catatonic schizophrenia pass suddenly from a state of stupor to the state of extreme excitement. During these frenzies episode, they make short, talk rapidly, pace back and forth, or act out in violence, either towards themselves or others. People with catatonic schizophrenia can be highly suggestible. They may automatically obey commands, imitate the action of others, or mimic what others say. We name this echolalia or echopraxia, when patients repeat some phrases or some actions after the doctor or other people, and when patient without motivation refuse to follow instructions, or we name this negativism. And if the patient makes some oppositive things, for example, we ask to give hand, but the patient hides the hand, we name this active negativism. What's the prognosis of schizophrenia? Numerous international studies have demonstrated favorable long-term outcomes for around half of those diagnosed with schizophrenia, with substantial variation between individuals and regions. One retrospective study found that about a third of people made a full recovery. About a third showed improvement, but not a full recovery, and a third remained ill. The World Health Organization conducted 2 long-term follow-up studies, improving more than 2,000 people suffering from schizophrenia in different countries. These studies found patients have much better long-term outcome in developing countries like India, Colombia, and Nigeria than in developed countries, USA, United Kingdom, Ireland, Denmark, Czech Republic, Slovakia, Japan, and Russia. Despite the fact of antipsychotic drugs are typically not widely available in poor countries, raising questions about the effectiveness of such drug-based treatment. And now let's talk about the treatment of schizophrenia, about the pharmacology of antipsychotics and their side effect, and about And about psychosocial counseling and psychosocial interaction of schizophrenia and treatment of medicationally resistant form of schizophrenia. So the final goal of treatment, schizophrenia treatment, is to ease the symptoms and to cut the chance of a relapse or turn of symptoms. Treatment of schizophrenia may include medications. The primary medications used to treat schizophrenia are called antipsychotics. These drugs don't cure schizophrenia but help relieve the most troubling symptoms, including delusions, hallucinations, and thinking problems. Many people with schizophrenia may be treated as outpatients, but hospitalization may be the best option for people with severe psychotic symptoms, who might harm themselves or others and who cannot take care of themselves at home. So, for treatment of schizophrenia, we use antipsychotics, and there are two generation antipsychotics, but modern researchers believe that there are third generation on antipsychotics, which involve dopamine and serotonin system. So the pharmacology of antipsychotics, let's follow to the video. It's a short video, but the main pharmacological effect and why some side effect appeared, you can see at this video.
In this lecture, we are going to cover pharmacology of antipsychotics. So, antipsychotics are a class of drugs used primarily to treat psychotic disorders, such as schizophrenia, mania due to bipolar disorder, and severe depression. Now, in order to gain better understanding of mechanism of action of antipsychotic drugs, first we need to discuss the role of dopamine in the development of psychosis.
Excuse me, I check.
The monoamine neurotransmitter, dopamine, plays a key role in the so-called dopamine hypothesis, which argues that the unusual behavior and experiences associated with psychosis can be largely explained by changes in dopamine function in the brain. Now, dopamine has four major pathways by which it affects the brain. Number one, the mesolimbic pathway, which is thought to be hyperactive in schizophrenia and to mediate positive symptoms of psychosis, such as delusions and hallucinations. Number two, mesocortical pathway, which is thought to be underactive in schizophrenia and thus mediate negative psychotic symptoms, such as loss of motivation and social withdrawal. Number three, the nigrostriatal pathway, which is part of the extrapyramidal nervous system and controls motor function and movement. Deficiency of dopamine in this pathway can lead to dystonia and Parkinsonian symptoms, while excess of dopamine can lead to hyperkinetic movements such as tics and dyskinesias. The last major pathway, number four, is the tuberoinfundibular pathway, which controls prolactin secretion. Specifically, dopamine in this pathway inhibits prolactin release. And as a reminder, prolactin is a hormone that enables milk production and is also involved in the control of sexual desire and regulation of immune system. Now, within those different pathways, dopamine interacts with specific receptors that mediate functional effects of dopamine. There are 5 primary types of dopamine receptors, known as D1, D2, D3, D4, and D5. Out of the 5, D1 and D2 receptors are found in the highest density in nearly all of the pathways involved in psychotic disorders. However, D2 receptors are the most clinically relevant because they are the main targets of antipsychotic drugs. Now, antipsychotics can be grouped into older, first-generation agents, known as typicals, and the newer second-generation agents, known as atypicals. The first-generation typical antipsychotics all share the same main therapeutic goal, that is to block D2 receptors. Furthermore, typical antipsychotics are not selective for any of the 4 dopamine pathways, and thus will block D2 receptors in almost all areas of the brain. This has positive as well as negative consequences. So, blockade of dopamine receptors in the mesolimbic pathway reduces positive symptoms, such as delusions and hallucinations, which is beneficial. However, blockade of dopamine receptors in the mesocortical pathway that is already underactive in schizophrenia may cause worsening of negative symptoms and thus lead to diminished energy, lack of motivation, restrictions in emotional and verbal expressiveness, and social disengagement. Furthermore, blockade of dopamine receptors in the nigrostriatal pathway may lead to extrapyramidal disorders, tardive dyskinesia, and Parkinson's-like symptoms, such as tremors, muscle rigidity, and difficulty in starting and stopping movements. Lastly, blockade of dopamine receptors in the tuberoinfundibular pathway may cause increase in blood prolactin levels, which then may lead to galactorrhea, gynecomastia, and sexual dysfunction. Now, based on their affinity for D2 receptors, typical antipsychotics are often subclassified as high potency or low potency. The examples of high potency antipsychotics are haloperidol, fluphenazine, prochlorperazine, and trifluoperazine. The example of low potency antipsychotic is chlorpromazine. So generally speaking, the high potency agents produce stronger antipsychotic effect at relatively low doses. However, they also tend to cause more extrapyramidal side effects and greater increase in prolactin levels. On the other hand, the less selective low potency agents do not bind to D2 receptor as tightly as the high potency agents and generally affect a range of other receptors, including alpha-adrenergic, cholinergic, and histamine receptors. This can result in a variety of side effects. For example, blockade of alpha-adrenergic receptors can lead to orthostatic hypotension. Blockade of muscarinic receptors can lead to anticholinergic symptoms, such as dry mouth, blurred vision, difficulty urinating, and constipation. And blockade of H1 histamine receptors can lead to sedation and some weight gain. Now, let's move on to the second generation atypical antipsychotics. In contrast to typical antipsychotics that primarily block only D2 receptors, atypical agents appear to block both D2 receptors as well as serotonin receptors subtype 2A. Because serotonin inhibits dopamine release, agents that block serotonin receptors may increase dopamine levels in brain areas that need it. Furthermore, atypicals occupy D2 receptors transiently and dissociate quickly, allowing for relatively normal dopamine neurotransmission. This modest D2 receptor blockade in combination with serotonin receptor blockade is thought to significantly lower the incidence of extrapyramidal side effects, as well as decrease negative symptoms and improve cognition compared to typical agents. The examples of atypical antipsychotics are aripiprazole, clozapine, lurazidone, olanzapine, quetiapine, risperidone, and ziprasidone. Now, in addition to dopamine and serotonin 2A receptor blockade, atypical antipsychotics also bind to many other targets, including other subtypes of serotonin receptors, as well as histamine, alpha-adrenergic, and muscarinic receptors. As a result, the side effects of second-generation agents can vary depending on the drug's receptor binding profile. So, for example, atypical antipsychotics that have strong affinity for serotonin receptors subtype 2C, such as clozapine and olanzapine, may cause metabolic side effects, including weight gain, hyperglycemia, and dyslipidemia. Agents that have strong affinity for H1 receptors, such as clozapine, olanzapine, and quetiapine, may cause sedation and may also contribute to weight gain. Agents that have significant affinity for alpha-1 adrenergic receptors, such as clozapine and risperidone, may cause orthostatic hypotension. In addition to that, out of all second-generation agents, risperidone seems to have the strongest affinity for D2 receptors, and because of that, it has the highest potential to induce extrapyramidal side effects and hyperprolactinemia. Lastly, clozapine is the only antipsychotic that can cause serious condition called agranulocytosis that occurs when the bone marrow does not produce enough white blood cells called granulocytes. Because this condition can be fatal, periodic blood cell counts must be performed to ensure patient safety. And with that, I wanted to thank you for watching. I hope you enjoyed this video, and as always, stay tuned for more.
So, and we continue the lecture. You understand with the side effect of antipsychotics, it's really important because you know that the patient with schizophrenia should take medication during lifetime course. So, for long period of prescription, as a rule, the antipsychotics of the second generation are chosen. But they, in some cases, they cause very severe endocrine side effect like weight gain, like hyperprolactinemia, or diabetes of second type, medicationally induced diabetes of second type. So in this case, we should change this medication for the other one from the same group or to the other group. And a typical antipsychotics, you can see here the original and generic name of medications. Aripiprazole, it's Abilify. Azanapine is Safris, brexpiprazole is Rexulti, cariprazine, Vralar, clozapine, clozaril, iloperidol, Fanapt, lumateperone, it's Keplita, lurazidone, Latuda, olazapine, Zyprexa, paliperidone, Invega, quetiapine, Seroquel, risperidone, Risperdal, and ziprasidone, it's Geodon. Clozapine is the only FDA-approved medication for treatment schizophrenia that is resistant to other treatment. It's also used to lessen suicidal behaviors in those with schizophrenia who are at risk. So it's an important point. The other way of treatment of schizophrenia, it's electroconvulsive therapy. Electroconvulsive therapy, in this procedure, electrodes are attached to the person's scalp, and while they are asleep under general anesthesia, doctors send a small electric shock to the brain. A course of electroconvulsive therapy usually involves 2-3 treatments per week for several weeks. Each shock treatment causes a controlled seizure. A series of treatment over time leads to improve in mood and thinking. Scientists doesn't fully understand exactly how ECT and the controlled seizures is caused help, but some researchers think ECT-induced seizures may affect the release of neurotransmitters in the brain. ECT is less well prone to help with schizophrenia than depression or bipolar disorder, so it isn't used very often when mood symptoms are absent. It can help when medication no longer work or if severe depression or catatonia makes treating the illness difficult. So now we'll watch a short video about electroconvulsive therapy.
ECT stands for electroconvulsive therapy treatment. Historically, ECT has always taken place behind the scenes, but there's no good reason for this. It's probably the most effective treatment we have in psychiatry. ECT is also a very safe and effective evidence-based treatment. The type of patients we see in the ECT clinic are patients that are really severely depressed. So maybe haven't been eating or drinking, have lost all hope of feeling better. Our main aim at the beginning is to make them feel as comfortable and as relaxed as possible. Then there would be anaesthetised, so they'd be asleep for the procedure. A small electrical current is passed through the patient's head to simulate a seizure. This is all done in very, very controlled circumstances, and the seizure only lasts for seconds. ECTAS is a nationwide accreditation scheme run by the Royal College of Psychiatrists, which is really basically to compare ECT services with evidence-based standards. The Isle of Wight ECT clinic has been accredited excellent 3 times in a row now. There are many clinics UK-wide. Approximately half of them have been awarded excellent. I'm really proud and passionate about our team because it encompasses the 3 values of the trust, from the manager to provide the resources to run the clinic, to the anaesthetist and ODP, the doctors, nurses, support workers, teamwork at its best.
Okay, so
Метод антишколи англійської – це коли готові.
So now let's talk to them about psychological treatment of schizophrenia. Psychological treatment of schizophrenia includes several approaches. First of all, it's coordinated specialty care. This is a term approach towards treating schizophrenia when the first symptoms appear. It combines medicine and therapy with social services, employment, and educational intervention. The family is involved as much as possible. Early treatment is key to helping patients lead a normal life. So, what type of psychoeducational information the patient and the members of patient family should receive on the primary period after onset of schizophrenia? First of all, it's information about first signs, about signs of relapse. It's information about medication which used for treatment of schizophrenia, the rules of prescription, the duration of treatment, and side effect and monitoring of this side effect. It's really important because very often the symptoms of relapse are invisible for patient. The patient has not awareness about the changes of his mental condition, but the family members can suspect and can observe the patient, the first signs, and start to connection with doctor for changes of doses of medication or prescriptions of some additional treatment. The next, psychosocial therapy. While medication may help relieve symptoms of schizophrenia, various psychosocial treatment can help with the behavioral, psychological, social, and occupational problems that go with the illness. Through therapy, a patient also can learn to manage their symptoms, identify early warning symptoms of relapse, and come up with a relapse prevention plan. Psychosocial studies include rehabilitation, which focused on social skills and job training to help people with schizophrenia function in the community and live as independently and as possibly. Cognitive remediation, which involve learning techniques to make up for problems with information processing. It often use drills, coaching, and computer-based exercises to strengthen mental skills that improve attention, memory, planning, or organization. Individual psychotherapy can help the person better understand their illness and learn coping and problem-solving skills. It's really important because a patient with schizophrenia characterized by the social, more sensitivity to the social stress. It means the level of stress which can impact to the patient activity, to the patient functioning, is less than in normal people. And the patient should be ready to this statement, and he should be ready to recognize what environmental factors can be stressful for him and try to avoid them, or to give some other meaning, non-dangerous meaning, and should have new behavioral strategies to cope with this stress. The next is family therapy, which can help families deal with a loved one who has schizophrenia, enabling them to better help their loved one. And group or therapy or support group, which can provide individual support. And now I would like to talk about some important myths. Which connect schizophrenia treatment process and people who suffer from schizophrenia. Very often people interested in are people with schizophrenia dangerous. So popular books and movies often depict people with schizophrenia and other mental illnesses as dangerous and violent. This usually isn't true. Most people with schizophrenia are not violent. More typically, they prefer to withdraw and be left alone. When people with mental illness do take part in dangers or violent behaviors, it's generally a result of their psychosis and the fear that they are being threatened in some way by their surroundings. Drug and alcohol use can make it worse. On the other hand, people with schizophrenia can be a danger to themselves. Suicide is the top case of premature death among people with schizophrenia. So you as a physician should keep in attention this information and perform different interviews and psychometric scales for suicide prevention in group of patients with schizophrenia. What are the cultural references? A book and film, A Beautiful Mind, chronicles the life of John Forbes Nash, a Nobel Prize winning mathematician who was diagnosed with schizophrenia. Marathi film DeRay featuring Atul Kulkarni is a presentation of a patient with schizophrenia. The film set in the Konkan region of Maharashtra in western India shows the behavior, mentality, and struggle of the patient as well as his loved one. It also portrays the treatment of his mental illness using medication, dedication, and plenty of patience by the close relatives of the patient. Other factual books have been written by relatives or family members. Australian journalist Anna Davidson told the story of her son's battle with schizophrenia in Tell Me I'm Here, later made into a movie. In Bulgakov's Master and Margarita, the poet Ivan Bezdomny is institutional and diagnosed with schizophrenia after witnessing the devil Walland predict Berlioz' death. The book, The Eden Express by Mark Vonnegut, recount his struggle into schizophrenia and his journey back to sanity. Also, you know that there are many artists painted who suffer from schizophrenia, and during their life course and when we observe the picture of them, we can see that the signs of schizophrenia interrupt the normal activity to creativity, to making some beautiful things. And the first stages of disease, people can create some unusual things because of the psychotic symptoms, because of the depersonalization, derealization, because of the presence of unusual experience and unusual perception of surrounding. They usually can see reality in some other ways, and if they are able to make them on the paper, they do this. But in some years after the onset of schizophrenia, when cognitive symptoms increase and negative symptoms appeared, we observe that the patient lost the ability to the emotional response. They have no any pleasure from the life, and all the life characterized by the anhedonia, and we can find this in his poems or in his painters. It's again the example of pictures making by schizophrenic patient. So So you can see the examples of depersonalization, disorder of self-consciousness, when this disorder like feeling of splitting of mind, influence of external powers and external forces to the mind of the patient. Okay, thank you for your attention.